Do you need me to use this one, or you want me to use this one on now?
You'll use
This one. Okay.
Yep.
Okay. Hello, everybody. Good afternoon. Hope you're all doing well and settling into your lunch. So, my name's Rick Bennett. As you mentioned, I'm a urologist. I came here to Sparrow probably about 5 years ago. I grew up, I was raised in this area. My first talk that has the big M on it now, so that may be a little tough for me to swallow at times. But you had just a big gala here at Sparrow and U of M combined, where we did the first gala here, and they did a great job, I think, of integrating those two systems. You know, they had an ex-football star from each program come in, and everybody's going to be friends now. So I thought it was a great way to do it. Because when we're talking about healthcare, I think that is important, right? We're not adversaries in any way, University of Michigan and Michigan State, when it comes to healthcare and taking care of the community. So I think U of M is bringing a lot of good things to our neighborhood now, right? So that's my apology for the M on those slides, right? So we're here to talk today just about urologic issues in the aging population, right? I'm standing up here as a 50-year-old guy, so I can tell you, if you remember the commercials back from the 80s about, you know, it's not just the hair club, I'm not just the president, I'm a member. Well, that's not the only phase of this, right? As a 50-year-old guy, I need a urologist myself as well. So I think just things change with our age and our health, and I'm here really today just to give you information about issues and health concerns that you may face, just to provide you with that information and maybe some things about treatments and lifestyle issues and things that can help, just so you're aware of what they are. And if something strikes you as, boy, I really would like to talk to a physician about that, then hey, that's what I'm here for today. I'm going to try not to get into too in-depth about treatments or surgeries or other things, because I know that's maybe not the audience today. I do a lot of med student lectures, resident lectures, lecturing to other physicians on certain topics, and so try to keep this more at the level of understanding rather than surgery techniques or something like that, right? So apologize if the title for the slides became a little cute today, but leaks, lags, and letdowns, because what are we going to focus on mostly today? Urinary incontinence, that's the leaks. Issues for men, slower urination, there's your lag, and the letdowns. You know, as we change with age, erectile dysfunction is let down by our bodies in that way, right? So not to make fun or belittle any of those problems, that's what we're here for to talk about today. So just our agenda slide here, we're going to talk about incontinence both in men and women, different reasons, different causes, and different genders. So we'll get a little bit into that. Specifically on the male side of things, BPH, benign prostatic hyperplasia. That is specific to men, as women don't have a prostate, so we all have our own unique issues. Men have prostate problems, women have their own. Erectile dysfunction, so once again there we're talking about the male health component of it, but a big component of relationships, right? I see a lot of men come to see me, been married 20, 30, 40 years plus, and when they start to have these issues, sometimes in relationship issues, depression and other things that can sometimes talk about that. Hypogonadism, once again on the male side, if you're noticing a slight slant in this, I will admit it, because I'm more of a men's health urologist. We are going to talk about a lot of female components as well, but my partner, Dr. Bartley, who will probably give you one of these talks later in the year, does specialize only in urologic concerns. So you'll get the 80-20 on my side, on the men's side probably today, and you'll probably get the 80-20 on her side a little later in this year, okay? They be medications, device-based treatments, and we'll talk about lifestyle, prevention, physical therapy, exercise, stretches you can do. We'll get into some of that as well. So we'll start here with urinary incontinence for both men and women. So little puppy there on the side. It's a little cuter to see it that way. I just left my puppies to come over here today. But I know when it happens to us as adults and as humans, with men and with women. So there's different kinds of incontinence. We kind of have to understand the definitions before we can get into causes and treatments, right? So stress incontinence is much more common in the female population, especially as the pelvic muscles change, as childbirth changes things. Women are much more prone, just from an anatomy or a way we're built standpoint, to have stress incontinence. Stress incontinence is not like lifestyle stress, like I had a tough day, I had a bad day at work. It's stress on your body. Coughing, sneezing, laughing, lifting things, even sometimes getting out of the car or crossing your legs when your bladder is full. Those things put pressure or stress on your bladder. And in women, it is much more common. But men, it is a common problem after prostatectomy and prostate surgery sometimes, where if we alter your prostate, we open things, then sometimes that flow is hard to control in men as well. So men do have that problem. It's just usually for a very specific reason of prostate surgery, pelvic surgery, or other things that have changed their anatomy in a surgical way for the most part. Urge incontinence. This is also common, but now we're talking about men and women both. The urge to go to the bathroom. So if you're leaking urine after you felt like you needed to go, you just don't have enough warning to get there. That's the urge incontinence, the urgency, that feeling like I have to go right now. So I'll usually talk to my patients about it. If you're on the phone having a conversation and you need to go to the bathroom, can you finish that conversation and walk to the bathroom? Or do you need to hang up and say, I'll call you later? Or if you're on your way to the bathroom and someone's in front of you, are you pushing people out of the way to get there? And if that's true and you can't make it in time, that's the urge incontinence part of it. And that can happen to both populations, men and women. We'll talk about that as well. A little bit easier to treat that sometimes with medications, diet, and lifestyle changes, whereas stress incontinence in both men and women often becomes a surgical treatment solution. Overflow incontinence, not too common, but happens in men and women once again. This is if you're not emptying your bladder fully, then as new urine comes in, urine will leak out. The bucket is full, so to speak. So if it's full, you pour some more in, some more has to come out to make room. So some people don't understand and can't feel that that's happening to them. They just know they're leaking urine. That's up to your physician or your urologist to help you figure that part of it out. Just had somebody in the office recently came in with an incontinence issue, but felt like he was urinating okay, and we did a check of his bladder with a machine we call a bladder scanner, like a little portable ultrasound. Had over 1 liter in his bladder, even though he had just left the bathroom, and had no idea, didn't feel like that was happening, couldn't tell. To figure out if you're in this what we call overflow incontinence phase. And we won't talk too much more about that today because that's a small population of people. Functional incontinence, a little bit different, has to do with physical impairment that would prevent you from getting there quickly. Let's say you need your hip replaced, you just had your hip replaced, you're using a walker, your house is not set up well for that. If it's going to take you 15 minutes to get out of bed, get ready, and get to the bathroom, you may have incontinence for that reason. Well, that's a little different cause for it. That is just a functional issue where something has changed with your mobility that's not letting you get there in time. Okay. Treatments for urinary incontinence. So if we're talking about on the female pelvic floor part of things, a big part of this can be pelvic floor exercises. So we have pelvic floor physical therapists through Sparrow and a couple other private places in town that could help with this, teaching men and women both specific exercises to strengthen their pelvic muscles. Most people are familiar with what we call the Kegel exercises. That's just part of it. Women a lot more familiar with that than men for the most part, but our men, once again, who have this stress incontinence after prostate surgery, we're teaching them how to do these Kegel exercises as well, because it helps you tighten what we call the sphincter muscles. That's what helps you hold back your urine. Once the prostate's gone in men, there's nothing holding back that urine flow other than their sphincter muscle. And frankly, in men, our sphincter muscles get lazy because our prostate's in the way our whole life and we're working to urinate instead of urinating freely and easily. So when your prostate's removed and your sphincter muscle's not strong, it's much more easy for you to leak. But common issue in both men and women. There are medications we can use for urinary incontinence, for stress incontinence, where it relaxes your bladder and it helps give you that urge to get to the bathroom. And behavioral therapies, not drinking a couple hours before bed. That's one thing we talk to patients about if they're getting up or leaking at night. We'll talk about avoiding caffeine, other stimulants, and alcohol, as that will make you urinate more and can irritate your bladder. And some people have their own specific triggers. Some people, 3 days a month, it's really a lot worse than the other days. Okay, well, what did you eat? What did you drink? What were you doing that day? Were you under a lot of stress? Did you eat Indian food for lunch? And all of a sudden, the rest of the day was urgency and frequency of urination. So some people do have their own different triggers. Surgical treatments. So once again, we're talking about the stress incontinence here for the most part. Sling surgeries. So the sling surgeries, unfortunately, were in the news a lot. A lot of you probably heard about these mesh lawsuits and things years ago. But in what we call the urethral sling for women, those weren't the slings that were really pulled off the market and caused most of those problems. All right. So the urinary mesh slings for women for stress incontinence is still a large part of my partner, Dr. Bartley's practice. In men, we have male slings as well. Once again, we're talking about these guys after prostate surgery that have their incontinence. And then we've got some newer agents we're going to talk about, especially on the female side, are bulking agents. There's something new out called Bulkamid, which gives us a much longer, durable response. Because typically, over the years, when they've had these bulking agents for women, we call them, and I'll show you a slide about how this is done, They tend to be short-lived. They would work for a while, but your body would reabsorb them, they would change, and you would go back to leaking again. And one of these newer agents called Bulkamid is giving us a lot longer durability, so you're not having to have the procedure repeated over and over and over again. So it's become a lot better option recently, and I just want to make sure people are aware of it in case they've had other treatments before and kind of given up on it and said, well, if there's nothing new out there, I guess this is just how I'm going to live with it. And we'll talk about some potential surgeries for males with incontinence, something called the artificial urinary sphincter. I'm not going to get into too much today, but we have an artificial sphincter device to help men hold hold urine. It is also rarely used in women, but there are some circumstances where it's used in women as well. We talked about a sling can be done for men and women. And a new interesting device I'm doing, probably one of only 2 or 3 urologists in Michigan doing it so far, called the ProAct device, which I think is going to kind of make a big difference in incontinence for men. So this Bulkamid that we talked about briefly, this bulking that we talked about kind of bulks up the urethra. Can consider it like 2 speed bumps, one on each side of your urethra to provide resistance to the urine flow. So what you're doing is, with a special instrument and a camera, injecting under the surface this bulking agent. It pushes the surface up. You do that on both sides, and now you've kind of narrowed that urethra. Well, this is what men with BPH deal with that we're going to talk about. Their urethra is narrow. They're having to work to urinate. So if we close that space in the urethra, we're adding resistance. Adding resistance decreases the amount of leakage, and if we can bulk that up enough safely, then you'll urinate still easily and freely, but without leaking accidentally. So this idea has been around for a while, but previous agents they used didn't seem to have as good a durability as this new agent called Bulkamid. There's some natural breaks in the talk here where we can stop in case there's questions as well. So this is the ProAct device, which I'm kind of excited to offer to patients here in Lansing and in the southern area of Michigan here. And another doctor out of U of M, Maine, and Ann Arbor is doing this as well. And this is the same type of idea about collapsing that urethra somewhat and adding back the resistance. So this is very specifically in men who've had a prostatectomy or had their prostate removed, because those are the men that suffer the most from this stress incontinence we're talking about. And so what it is basically 2 small saline-filled balloons. And what you're doing is inserting one on each side under the bladder where the prostate used to be. So this is where a prostate used to be in this cartoon drawing, and by putting these balloons in and inflating them, you're pinching the urethra much the way the prostate used to do. Kind of one of the genius things about this is they have these little tails with ports on them, kind of like the hub of an IV, if you've ever had an IV at the doctor or the emergency room, where they can kind of inject medication in and out of your IV. Well, with this, we bury these ports under the skin, and we can put a needle through the skin, and we can add and take saline out of them. So we can expand and take some out of them if we need to. So patient comes in 6 or 8 weeks after surgery, we're doing better but not as good as we want, we can add another half a cc or a cc to the device, bulk it up a little bit more, and see if we get more improvement. So it's easily placed, low risk of complications, and it's adjustable. So I'm really excited about this new product we're offering. So just to kind of introduce that to the area here. We can stop 1 second there. That's kind of the stress incontinence section. If I see any hands, we can answer any questions, and we'll move on to some prostate issues. Intentionally kept the slide part short so we'd have a lot of time to even not subjects we covered directly in the slides today. So BPH, or benign prostatic hyperplasia. So most men, this is not a if I'm going to have prostate issues, it's when I'm going to have prostate issues. Unfortunately, as men, our prostate grows as we get older. Every man in this room who has a prostate still, it's growing while we're talking. It's just happening slowly. So whether you're 40 years old, 50 years, 70 or 80 years old, at some point you're going to notice changes in your urination. It's slower, it's weaker, I'm going a little more suddenly, I'm starting to get up at night. That's just usually how it starts. Or even in some people in their 30s, it drips a lot after I'm done. Sometimes that's one of the first things we hear. So there are some medications we'll talk about. There's some surgeries and procedures we'll talk about once again, because urologists were kind of surgical subspecialists. So some of the things we do involve surgeries and procedures. But first, a little bit more about what BPH is, right? So here's a little cartoon drawing showing you kind of the prostate of maybe like a 30-year-old and the prostate of somebody who's had a little more experience in their life. So as our prostate grows, it grows kind of in a nodular way. It's a little unusual, like the knots in a pine tree if you see pine paneling in the old basements and stuff, right? And so our prostate grows in unusual and nodular ways. It doesn't always grow evenly, which is what that picture is representing, but you can see what it's doing to this urethra right down the middle. On that right picture, you can see kind of an open channel for the urine to flow. You can see that almost completely pinched off in this one here. And that's what adds that resistance to the flow, like the opposite of the stress incontinence we were just talking about. It is difficult to urinate. You have to work and push hard to get that urine to move through there. You may not be able to get it all out every time. Then you're not emptying the tank. Then you end up back in the bathroom more often because your functional capacity, we call it, be less. Like, let's say your bladder holds 400 milliliters of urine and you empty 200 each time. Well, then it's going to fill back up more quickly, right? Because you've only got a 200 usable capacity out of the 400 because you're not emptying it all the way, right? That's what causes the ongoing back a lot. So the common symptoms are frequency, straining, weak stream. It's very important for your doctors to get your medical history about those symptoms and differentiate them from other things like blood in your urine, pain with urination, things that could be infections. Physical exam, we're a little limited in our physical exam for prostate because there's only one way for us to estimate a prostate's health, and that is through the rectum. No guy likes what we call the digital rectal exam, but it's usually a part of your yearly urology visit. Allows us only to feel the back of your prostate. So as an experienced urologist, that helps us kind of estimate the size, and we're feeling for any nodules or anything that could be unusual in a cancer standpoint. But mostly when the urologist does your rectal exam, it's to give us an idea of the size and the texture of the prostate, more about the enlargement for most guys, although it is an important part of testing and screening for prostate cancer. So that's our physical exam. We're limited there, but we do have some testing we can do in the office. I talked to you a minute ago about this bladder scan, or PVR we call it, that allows us to check your bladder for how much you're holding back. You leave the bathroom, in theory, when we're young and healthy, our bladder empties 100% every time. Well, if it doesn't empty 100% in a man, that's usually a BPH related issue, unless you have another neurologic issue like Parkinson's disease, multiple sclerosis, or other reasons that could happen. So we have some other tests. We can do a urine flow test. We can have you urinate into a machine that'll check the speed and the flow of your urine. So we have some other tests we can do to kind of help us judge those, but we are a little limited in how to evaluate that. Most of it is a history. I get most of my information about talking with patients. So that's our diagnostic test section there as well. So treatments. So on your picture slide there with hundreds of medications. So we do have a lot of medications to choose from, but I know that's not a lot of people's first options. Or if we're failing medications, we always want to know about other options that are available, because medications have costs, they have side effects. Some people, a prostate medication might be the first medication they ever need to take in their life. So, you know, if I see a guy in his late 40s, early 50s, his blood pressure's been good, he's not diabetic, a medication for his prostate might be the first medication a doctor is talking to him about if he's otherwise been pretty healthy. So a couple categories here, something we call alpha blockers. Used to see commercials for medication we call Flomax. Now it's called tamsulosin. That was the original one in this category. I would say somewhere in the neighborhood of 60 to 70% of men end up on that medication or a variation of it at some point in their life, right? So most guys have an experience with this at some point. So there's one called tamsulosin, uroxetrol, silodosin. There's three major ones in this category. But they can have side effects: dizziness, lightheadedness, especially with standing up quickly, nasal congestion, changes in sexual function in some ways. So there are, in some people, side effects of those medications, but they can drastically improve the flow, the stream, and allow you to empty better in those earlier phases where you're holding back urine. So usually that's where we'll start. Another medication, we'll talk about how those work. They more like relax your prostate. They're not changing the physical size or the structure of your prostate. They're relaxing your prostate to help you urinate better. But we move on to the next category here about these, what we call 5-alpha reductase inhibitors. They actually can shrink your prostate. So it's a longer process. I'll tell people when they go on this medication, don't expect anything this week or next week, but 2, 3, 4, 5 months from now, you may see an improvement. And the version of you 2 to 3 years from now may urinate better than the version of you 2 to 3 years from now without it. So this one's more like the investment in your future kind of thing, more like going on a blood pressure pill even though you feel fine, about what's our health going to be like down the road. One issue with this medication, some of the side effects can be mild, but they added a warning to the medication years ago that some of the side effects could be permanent, even if you go off the medication. So I think the prescriptions written in this category really dropped 8 or 10 years ago when they said things like fatigue and sexual dysfunction, if they happen from this, could be permanent. Now, it's a low percentage of people who have it. and it's a really low percentage of people who have that side effect where it's permanent. But I'm a little careful about giving this medication to people who are still sexually active, sexually vibrant, working, very active, because I don't want them to be tired, fatigued, or have sexual changes that I have to warn them could be permanent. So in this medication, we're a little more careful. Symptom management, in some people it's just about, like we said, urinating before you go to bed, maybe setting an alarm to get up at night if you're having urine control problems at night, watching your caffeine and your alcohol, because those will all kind of exacerbate this, right? If you're having trouble emptying and then you're, let's say, drinking a lot of caffeine, which makes you pump out urine faster, well, then you're just kind of exaggerating the problem and you're going to make the symptoms seem worse. So avoiding some of those things can help people kind of live on that edge of, I'm not ready to take a medication yet, but I don't urinate like I did when I was 25 kind of thing, right? So sometimes I'll have this discussion with patients and they'll be like, I'm not ready for a medication yet. Table that discussion maybe until the next year or the year after that then. Optional surgeries or interventions. So as time goes on, this is something that we've been offered a lot more procedures in the what we would call like minimally invasive technique. Ultimately, what this comes down to is what we call physics and fluid flow. So we've got all these equations in physics. If I'm getting into this with students or residents, we can talk about, but basically the narrower a channel through which you're trying to move a fluid, the higher the resistance. So the narrower that urethra tube is, the higher the resistance, the more pressure your bladder has to generate to get that flow. At a certain point, you just can't generate the same pressure to get the same flow you used to. That's as simple as we can make it, right? If you can open that channel and decrease the resistance, then you can get that flow back with not needing as much force or as much pressure. So almost all these procedures for the prostate are going to talk about how do you open that channel. And there's different strategies and different approaches that have been invented. So the one that's been around the longest and probably still the gold standard is what we call a TURP, if you've ever heard of it. So some people have heard that acronym, but they don't know what it stands for. It's transurethral resection. Resection means removal of the prostate. So rather than removing an entire prostate like we would for prostate cancer, what we can do is put a scope or a camera in while someone's asleep and kind of open that channel, make that channel wider. Going from a 2-lane road to a 4-lane highway, just shut the road down for a few minutes, put out the cones, repave the sidewalks, and make your road wider, right? I think in Michigan, we're all familiar with those road signs right now. So we're going to open that road, so to speak, right? And so, yes, it's a surgery, it's a procedure, there's some recovery, you need a catheter for 1 or 2 days, there's a little blood in the urine for up to 2 weeks in some people. If you're on blood thinners, that can be longer. There are considerations with it, but as an idea, it's been around over 40 years. The equipment has changed, the procedure's gotten drastically better. Side effects and complications have gone way down over those years, but the idea of putting a camera in and open someone's prostate with an instrument or tool is old as I am, okay? Urolift, that's another procedure. I've got some slides I'll show you on. This is a way to kind of physically open the prostate without removing any tissue. It's kind of like if you're trying to look out the window, your drapes are closed, and you open the drapes so you can see out again. I'll show you a picture of what that looks like. Resume is a steam heating treatment. Our office doesn't do it. There's a couple of urologists in town who do provide it. I've referred people to other people if they really were interested in this procedure. Basically, needle injections of heated steam into the prostate, kind of superheats it a little bit. Think about it as it's heating, those cells die off and it retracts. So it's kind of shrinking the prostate by superheating it for a short time, done by putting little needles in it through a scope and heating it. Once again, after it heals, it retracts and opens that channel, but by not scraping it at all, but kind of like just killing that surface area so it retracts back. There's a procedure called an iTind, which is a newer procedure I'll show you a quick slide on. That's more about what we call like a pressure necrosis. The way I describe this to people, kind of like if you've ever seen the Grand Canyon or one of the large gorges, it's kind of amazing to think that those were made by a small river over thousands of years. But constant pressure on something over time causes what we call erosion. So there is a device now that we can put inside the prostate, deploy it. It puts pressure on your prostate for about 5 days, and then we remove it. And when we remove it, it's created little channels or openings in the prostate to open that channel and help you urinate better. So we haven't cut, we haven't removed, we've eroded into the prostate a little bit, so to speak, we'll call it. And you take the device out, it's not permanent, and you urinate better in a certain population of patients that's ready for. In people with really big prostates, none of those are an option. The bigger the prostate gets, the more limited we get on our surgical treatment options. There's a procedure we're not doing here in Lansing, but the main U of M in Ann Arbor is providing it, called prostate artery embolization. This is where a radiologist, not a urologist, actually goes in, shoots in X-ray dye, and blocks the arteries to your prostate from the inside. So it's kind of like giving your prostate a heart attack. We're blocking the blood flow to it on purpose instead of by accident. But the prostate responds in a different way, and just by not having enough blood flow, but still some blood flow, it shrinks. All right, so it takes a few weeks for symptoms to start to improve. It can take 3 to 6 months to get your best improvement. But this prostate artery embolization is what we would call a minimally invasive procedure as well. You just get a needle puncture in your groin like people get if they're having a heart catheterization, having a stent put in their heart. No open surgery, as you would call it, right? So recovery from this very quick, 48 hours maybe of light activity, a little irritation of your prostate for a while, but very rapid recovery. And in patients with really large prostates, it's a good option. There's other prostate procedures for large prostates, but they get a little bit more involved. Laser enucleation of the prostate, and what we call a simple prostatectomy. Benefits of surgery. It is probably the way to get the channel open the best and get the best flow back, right? So if you're comparing a lot of medications to these procedures or surgeries head to head, you will get the closest to your 25-year-old urine flow as you're going to get with probably one of these procedures than the medication. But usually we'll treat medically first, and we'll treat with environment changes in lifestyle first. And then when we get to a point where those aren't successful enough and it's still impacting your lifestyle, you're getting up 4 or 5 times at night, you're tired during the day, you're having any accidents, or if there's any danger to your kidneys, then it's time to talk surgery. Or like I mentioned, some people, this is the first medication they're on. So if I have a 50-year-old guy who's healthy, he's getting a little dizziness from his Flomax pills, and he wants to talk about, let's say, the UroLift option. Get off the Flomax pills, get rid of the dizziness, not take a medication at all anymore, and just fix the problem itself. So, you know, being in a university town and more engineers maybe than some locations, like I get an engineer comes in to see me, he's like, well, why don't we just fix the physical problem instead of taking a pill? I wouldn't argue with that either. So some surgical procedure photos, we'll keep this limited, at least 3 out of the 4 are cartoons anyway. But that one on the top is that TURP procedure we talked about. I think you can just notice how you can urinate easier in that picture on the right than the left, right? So that's showing you the before and the after. Someone's prostate before the TURP surgery, someone's prostate after. You go in and you open that channel, you make it wider, okay? The UroLift procedure I talked to you about, that one that's kind of like opening your drapes, the prostate's actually quite spongy. So if you put an instrument into the prostate and push to the side, the prostate will move out of the way. And you can peek out that window, so to speak, but you let go, it's going to come right back. So what this device does very interestingly is fire these device retaining pins, I kind of call them, and then that holds the prostate open in that position where you've kind of pushed it. Then when you let go, it stays there. So what you're seeing there is kind of before, during, and after, and you can see how that channel has been opened by pulling it open or pushing it open, so to speak, and then putting this little device in there. These small implants are permanent, but the surface usually grows over it. So if you go put a camera in a couple months later, you can't even really tell it's there other than the channel is more open. So for certain patients, a good option. This newer one we just talked about here is on this side, just to show you kind of some of the newest technology. This is that iTin device. So you place this device in there. It's made out of what we call nitinol. Nitinol is a fancy word for kind of like a strong plastic with memory. So it has a memory to it. It's collapsed. You put it in, you take this sheath off of it, and it springs open, so to speak. But what it's doing is pushing up and at an angle on both sides. And like we talked about that erosion thing, that it's pushing into it. So once you take it out and it heals, now you've got more space because it's kind of elongated that urethra, if that makes sense to you. So you're making that channel bigger in that way. And this device sits in there for 5 days, and then you remove it. It needs to be placed under some sedation, 10-minute procedure to put it in, can be taken out in the office. 5 days later, 90-second procedure to take it out. So that's the end of the BPH section. Any questions on the issues, the medications? Yes?
The TX, is that technique? You have the word TX.
Treatment, usually, yeah. Yes?
So is there an age or a condition at which the physician stops physically examining the prostate to see if it's enlarged? So
you get to be in a little bit of a medical philosophical debate there, okay? Urologists have slightly different opinions than some internists, and I think most doctors have different opinions than the government. So where we got into a problem, God, I don't remember how many years ago now it was, probably almost 10, the U.S. Preventative Services Task Force, another one of these government committees with an acronym, they are basically in charge of like evaluating tests and procedures and deciding what they think Medicare should cover, right? So in whatever year this was, about 10 years ago, the Preventative Services Task Force, which by the way had no urology, decided that Medicare shouldn't be anymore. So urologists obviously got quite upset. It was a multi-year process to kind of fight them on that. We got them to backtrack on it. But in that time, a lot of internists, primary care doctors, general physicians stopped doing PSAs and rectal exams. And once we pushed that clock back a little bit, we'd already lost some ground in screening. A lot of people stopped doing it. I see a lot of guys who haven't had prostate exams in years. The PSA testing, say, okay, maybe it has some utility. We did change the recommendations. Like maybe we're doing a little less often, we're not doing it as early. So basically between the ages of 50 and 75, the Urologic Society guidelines recommend getting it at least every 2 years. You have a family member who's had it. If you're in a certain ethnic population that's at higher risk, maybe sooner screening, but urologists feel like the PSA blood test every 2 years from the ages of about 55 to 75. And with that, most urologists will still do the digital rectal exam. That is still debatable even amongst urologists. Digital exam doesn't give us too much information anymore, and we try not to base medicine on anecdotes, but in my 15 years of doing this, I have at least were normal. I felt a bump on their prostate exam. We did a biopsy, and they in fact did have cancer, even though their PSA test was normal. But of the thousands in PSAs that I've done, it is much less likely to find a prostate cancer that way than just a bump in your PSA test. So I had to choose between the two. I'd love every guy between the ages of 55, 50 and 75 to still get a PSA every year, even if they're not getting their exam. I still feel like it provides me information. And also, like we talked about, it gives me an idea of the size of someone's prostate, because usually if they're there to see me about their prostate in general, they're probably having some urinary symptoms as well. And that age range from 50 to 75 actually has to do more with life expectancy than the age of 75. It's not like you hit an age and your doctor shouldn't do it anymore. And kind of estimates of how long people are going to live. So it's more about, all right, prostate cancer is a slow process. So some guys can have prostate cancer 5, 10 years and not know about it if it's low grade. So we're really, if we're checking guys for PSA and prostate exams, we're checking about problems you're not going to know about for several years. We just stop checking that. Of it, and that's going to be an individual doctor-patient discussion, in my opinion. Because some people at 75, 80, 85 years old, I've got guys in their mid-80s, I'm still checking their PSA and their exam on because they're living independently, they're driving, they may be even still working part-time. I think those guys are going to be over 100 years old someday, so I'm still checking them because I had a health problem 5 to 10 years ago. If someone sees me and they're 60 and they've had 2 heart attacks, a stroke, their diabetes isn't well controlled, maybe that guy doesn't need his PSA checked, even though he's much younger. So it has to do with your overall health, your overall life expectancy, and those kind of things, right? So that's kind of the art and where the art meets the science part of it. So sorry, that's not an easy answer, but that's my opinion, right? Any other questions? Surgery, a lot of the side effects are kind of in the original phase. The catheter for a few days. There's some blood in the urine on and off, especially if you need to go back on any blood thinners afterwards. There's a low risk of erectile dysfunction afterwards, probably in the 3 to 7% range, so not high. But there's almost 100% rate of what we call retrograde ejaculation. Ejaculation doesn't come out anymore. When we open that prostate, your ejaculation comes through your prostate on the way out. That's just how the plumbing is. If we open someone's prostate, things follow the path of least resistance. So you get a nice open prostate after the TURP, terrific, you're going to urinate better. But when you ejaculate, it's going to make a wrong turn and go into your bladder instead of coming out the other way. That doesn't cause a problem. It's not painful. It washes out with the urine the next time you urinate, so it's not a major problem. It can happen with Flomax and all of the alpha blockers I talked to you about. So some guys on Flomax have that problem already. We're just making it permanent with surgery. So I always make sure I talk to guys about that. So they understand it, and afterwards they're not upset they did the procedure because of that sexual side effect. But most of the guys we're doing it for have been on the medications, and they may have already had that side effect. I just tell them it's then going to be permanent. Whereas like the UroLift minimally invasive procedure has almost a 0% chance of retrograde ejaculation. So when I talked about kind of a younger guy on one pill, wants to get off medication, doesn't like the sexual side effect of it, then that would be an option for them because it doesn't cause that problem. As far as other things would be like prolonged bleeding afterwards, going back to surgery, that kind of thing. It is about an hour and a half surgery, so there's general anesthesia involved. So your internist and your cardiologist need to clear you for anesthesia, those kind of things. All of these prostate procedures I would call temporary, right? We're not removing the entire prostate. One. So if we go in and we open that channel, great, we're urinating better, but the prostate's going to fill back in someday, right? The TURP opens it really wide. Most people will tell you to expect 10 plus years out of a TURP surgery of urinating well. Some people 15, 20 or more. I'll usually tell people years of this improving your urination. Some of the less invasive procedures, the Resume, the UroLift, the I-10, probably not as durable, right? So if the UroLift appeals to somebody, I'll tell them probably we're going to get 5 to 7 years. Symptoms come back. We could still, for example, do a TURP. We haven't crossed a bridge where we can't do that. That TURP device, the UroLift device, one of the ingenious parts of it is that so you haven't prevented somebody from getting procedures is durability, and you kind of have to look at that as a picture of it, right? If somebody's 55 or 65 years old versus 85 years old when we're doing it, somebody's 70 years plus and we do a TURP, probably improvement. Somebody's in their 50s and already they're having problems and we do a TURP, you're probably going to need another one later. So maybe we do something else first as a stage thing, we get 5, 7, 8 years better, then maybe we do the. So it's kind of hard sometimes to play that far in advance with the game, but I usually talk through it with my patients depending on their age and their symptoms. That answers the question? Okay. Anyone else? Okay. Oh, sorry.
That I wanted to ask, it may not fit perfect here, but a little bit of a PSA for the your guys' department. If someone is needing prostate cancer surgery, you alluded to some of it. What kind of advancements do you guys have? You can expound on a little bit more on why coming to Sparrow would be the selection to help best get possible.
Okay. So one of the things I love that we have here at Sparrow. Within the urology department, the oncology department, the radiation oncology department, in combination with radiology from the hospital, pathology from the hospital, every week there's a multidisciplinary committee that meets. So actually I'm missing it today to be here because the discussion part is from noon to 1, but from 10 until noon they meet with patients. So we have this system where, let's say you're a prostate cancer patient and you want to get the best opinion from all the physicians here at UM Health-Sparrow. You can come in, you can meet with 3 different doctors in the kind of what we call a round robin fashion. You stay in the room and the doctors switch rooms, right? You meet a urologist who does urologic surgery for prostate cancer. You meet a radiation oncologist who does radiation treatment for prostate cancer. You meet a medical oncologist who sometimes gets involved in medications to treat advanced prostate cancer. Then after you've met with all those doctors, we have a committee meeting. We sit down, we go through your chart and discuss it after everyone's met with you in person, because everybody's different on paper than they are in person sometimes, right? And we kind of come up with a committee consensus on, is there one treatment that everyone agrees would be best? Are there 2 that are pretty much equal and we can give you an option to choose between them? And then we come back to you with that recommendation. But there are patients also we can just put on for discussion if they prefer not to come in person, or maybe they're not quite as complex. We can just present on paper this person, this PSA, their age, their health, what the genetic profile of their tumor might look like with some advanced testing, and then come back to them with those recommendations as well. So kind of off the surgical topic, but in the kind of multidisciplinary realm, that is something fantastic we offer here that not a lot of places have. And out of that, I think, comes a better quality of care. As far as surgical treatment for prostate cancer, the biggest advancement happened back when I was still a resident in the early 2000s, where we moved to this Da Vinci robotic system for prostatectomies, prostate removal. So back when I started my residency, every prostate was moved through an 8 to 10 inch incision from your belly button down to your pubic bone, opened it up so 2 doctors could get their hands in there, do the work, take the prostate out, close it back up. Now it's all done through 5 incisions about the size of the tip of your finger. You do all that work on the inside to remove the prostate, pull it out through underneath the belly button, close those all up, much less invasive surgery. So that's gotten better and better over the last, 25 years since it's been out. But probably 90-some% of prostate surgeries are done that way throughout the country now. And Sparrow was kind of on board from the early 2000s with that, like a lot of places. So there's at least 4 very experienced surgeons at Sparrow in that robotic surgery. 2 of them being in my practice, one of them being kind of probably one of the world's best, trained at the mecca of that procedure in the Henry Ford. And so definitely wouldn't need to travel if that was a procedure you need, as we've got some of the best people around for that. The University of Michigan is sending people up to help us with our radiation oncology department, because we had some people leave. We've had a retirement of Dr. Herman, who's a pillar of our community here, whose name is on our building. He's been trying to retire for years, but they've been so busy, they've needed him. So hopefully Dr. Herman will get to enjoy his retirement now and just drive by and see his name on the building. So I think we have a great setup for this multidisciplinary system. We offer cutting edge surgery and radiation. And so I'm kind of proud of our department in that way. So thank you.
So what's the process when you remove the prostate?
Yeah.
Okay, so under what circumstances is cancer, right?
So we only remove the prostate for the most part for cancer, because the process of removing it can have complications. If you need to remove for cancer, you need to remove for cancer, but then we need to talk about complications afterwards, like the stress incontinence that we just talked about, because that doesn't happen to men unless you've had your prostate removed. And then sexual dysfunction, because unfortunately the nerves that give us erections run right on your prostate on a microscopic level. And to remove the prostate, you kind of have to brush and move those nerves aside and try to do that without damaging them, even though you can't see them. And so in almost all men who have their prostate removed, there is some sexual dysfunction, at least for the first 6, 8, 12 weeks, and then we hope it recovers, but it doesn't in everybody. And so the erectile dysfunction part we're going to cover later is also a part of the treatment for that. So we usually just kind of reassure men that we need to do this, we need to remove it, it's best for your overall health, but we might have to talk about how we help you control your urine and how we help you get your sexual function back. But the basics is basically you're taking that whole prostate out. So I went back to this picture. But then you can see that the bladder would no longer be connected to the urethra if you just take that out, right? So if we go back to the picture on that PROACT, well, that was back further. It's kind of showing you what that urethra looks like without a prostate. So you see that prostate's gone in this picture. You see it's just a long, thin urethra with nothing around it. These stitches are trying to represent kind of where that was rehooked up, because you have to take that urethra and bridge the gap where the prostate used to be. And so lacking that prostate is what causes that urinary incontinence. So you've completely removed the prostate in that case, but with it can come some side effects. That's why we don't do it for just the urinary issues, because these other procedures are less invasive with fewer long-term complications. But a large percentage of people, once they recover from that surgery, will get full urinary control back. And if not all, a lot of men will get their full sexual function back if they might need the assistance of a medication they didn't need before. So that's probably a good lead into our section then on erectile dysfunction, because that's probably the #1 thing guys are worried about going into that prostatectomy. Okay. So we'll talk about erectile dysfunction, right? So we'll talk about how it's treated. Yes?
Are you saying then that the prostate acts as the sphincter to hold urine in the bladder?
No, if you kind of recall what I said a little bit earlier, the way I think of it is it's providing resistance to the flow before it gets to your sphincter. Then our sphincters just kind of are lazy as men, because they're not needing to do much. The urine doesn't get to our sphincter as men unless you work at it. As your prostate gets larger, you have to try to urinate. You're having to push against the prostate. You remove the prostate, you remove all that resistance. If you saw that picture I showed without the prostate, it's almost now funnel shaped, like anatomically the best way to get that urine through there. But now if you cough or sneeze and there's nothing holding it back other than your sphincter, because your prostate used to kind of be in the way as a blocker, now you take that blocker out of the way, it's wide open, you sneeze, it might go through if your sphincter muscle is not strong enough. So then you have to work on strengthening that sphincter muscle, because the only thing that's going to hold your urine if you cough, sneeze, or laugh is that sphincter muscle now. So the prostate's kind of in the way unless you remove it. Once it's not in the way, things are wide open. That make sense?
In other words, strengthen the sphincter.
Yes.
Are there exercises for that?
So that's the one we refer to as the Kegel exercises. So when I'm telling guys how to do Kegel exercises, the basics of it are basically the same muscles you would try to stop your urine flow. So if you're in the bathroom, somebody startles you, walks in, you try to cut it off and pull up your pants, those are the muscles. So I'll have guys practice by standing there while they're urinating and trying to stop and start their urine stream. It's not easy. Try it if you want. So once you try to feel what those muscles are, you don't have to be urinating to practice it. Once you know how to do that, you can be in the car at the stoplight, you can be sitting in your chair at your doctor's office waiting for us for an hour, like sometimes happens, I'm sorry. So wherever you're sitting and waiting or in your car, you can do those exercises. And so once you know how to do them. Now, some people don't know if they're doing them right, they're having trouble learning them. The physical therapist actually have a little electrode device they can put on your underneath your perineal area, behind your scrotum as a guy, or next to the labia as a woman, and it picks up muscle twitches. And so we can see if you're doing the exercises right. If you don't know, we can get a physical therapist to help teach you and to put these little electrodes there, read the muscle twitches and be like, yes, that was a good one there. And then once you know what it feels like, it's easier to make that repeatable. So guys who are having trouble learning it, or they're still leaking even though they think it's doing it right, we'll send them to physical therapy as part of that treatment. All right. Dysfunction, we'll talk about causes. How are we doing on time here? Yeah. Oh, question.
You mentioned Parkinson's and the relationship with prostate. Could you touch on that just for a moment and fill us in on any details?
So Parkinson's gets complicated because it can cause almost opposing problems. It can cause urgency and frequency. I'm going all of a sudden, I can't hold it. But it can also cause the retention of urine, like I can't empty. What happens with Parkinson's is it affects how we control our muscles. So sometimes with Parkinson's, it starts to affect how we walk. It starts to affect our handwriting. Starts to affect how you reach for a glass of water, where patients with Parkinson's often have to really think about a process to make it happen, and there's a delay. So we don't think about our urinary sphincter, but it has to relax for us to urinate. Well, it's still a muscle. It has to relax. That's a muscle movement. And so sometimes with Parkinson's, it's hard to relax your sphincter muscle. And then it's like you're trying to push against a closed sphincter. Well, that feels just like a really big prostate. Something is blocking your flow. So in Parkinson's, guys, we have to be a little careful, because if you go and do a TURP surgery and open their prostate really wide, but really it was a Parkinson's problem, then they may go too far the other direction, have trouble controlling their urine. So I'm really careful about some of these procedures like a TURP in people with Parkinson's, because we could go from one direction of I'm having difficulty urinating to the opposite direction of I can't hold the urine anymore. So Parkinson's gets complicated because it can affect it in a couple different ways. The major one being control of your sphincter muscle and not tightening it, but relaxing it actually. Does that answer your question? Okay. Sure. So we'll talk about causes and treatments for erectile dysfunction. You know, I threw this little cartoon about MacGyver in here because you people are as old as I am at least, and so hopefully everybody remembers MacGyver. If I talk to my residents about MacGyver, they just stare at me. They don't know what it was. They never saw this TV show. So we're not going to fix it with a pencil and a couple of rubber bands. We're going to talk about some more advanced techniques. Yes?
I just wonder, I didn't understand the cartoon, what's the pencil and rubber band?
Yeah, so then you don't know MacGyver.
I don't know.
Okay. It was a TV show in the 90s where this guy would basically get himself out of situations with whatever was at hand. A couple of paper clips and a rubber band, and all of a sudden he's unlocked the door and stopped the nuclear bomb, right? So we've got more advanced techniques, and we don't need the paper clips and the pencils and the rubber bands to fix your erectile dysfunction. Although, interesting enough, one of the treatments is kind of like a large rubber band. But that's not in today's talk, okay? It's called a ring or a constriction device, and a lot of people find them on the internet for other reasons, but they do actually help men keep an erection. Physical causes, so things that cause other diseases and health problems in your life are the #1 causes of erectile dysfunction. Heart disease. If you have heart disease, if you have narrow arteries, if you've had a heart attack, it's because you have poor blood flow to your heart. Well, guess what an erection is? It's a high blood flow state to the penis. So if you have narrowed arteries in other places, your artery in your neck called your carotid, your coronary arteries in your heart, one of the arteries to your leg causing leg pain with walking, you're probably not going to have great erections either, okay? So anything that's affected your blood flow in other ways is highly likely. High blood pressure, high cholesterol for years. So when I'm seeing guys with high blood pressure, high cholesterol, and they've got some erection problems already, I will go back and ask them, how's your blood pressure been? Are you seeing the cardiologist? What blood pressure pills are you on? Not because I'm their heart doctor, but because protecting that is their best way to not get worse, right? So we want to look at also sometimes just not getting worse than we were. Diabetes. Diabetes is up in the top 5 of causes for erectile dysfunction because it damages arteries, it damages nerves, and those are 2 very important things for us getting erections. So I see a lot of diabetics, probably 70 to 80% of diabetics will have erectile dysfunction within the 10 years of getting diagnosed with diabetes, especially if their diabetes isn't well controlled. So very common in that population. Factors like stress and other surgeries. We talked about prostate surgery, but some other pelvic surgeries like low colon surgeries can cause issues like that. And we'll talk about kind of the evaluation with your physician. In this realm of things, doctors don't really have a lot of tests to do. Once again, I get most of my information from talking to patients here. There's maybe one test we have for erectile dysfunction, and I do it once or twice a year. It's called a Doppler ultrasound. We give you a shot, makes you get an erection. We ultrasound your penis. We check the blood flow. Ultimately, and most people, it doesn't change the treatment, right? So the treatments haven't changed too drastically. We've got some updates, some new things we'll talk about here on another slide. But the biggest revolution was all the way back in the 90s when Viagra and Cialis were invented, right? There's some other procedures and actually surgeries we'll talk about that were invented even before Viagra and Cialis came out. So where do we usually start? Okay, we just talked a little bit about diet and lifestyle changes, right? If you have diabetes, what's your blood sugar? What are you on for your diabetes? Have you tried to lose weight? How's the rest of your health? Let's make sure we at least arrest the problem or stop it from getting worse. Blood pressure, how's your blood pressure? How's your cholesterol? Let's work on all the other things in your life that might have gotten us here today when we're talking about erectile dysfunction. But if it was prostate surgery and your erections were great up until surgery and then never came back afterwards, well, that's a little different scenario and might take a little different treatment. There's nothing you could have really done to prevent that. So this class of medications that I was just mentioning that everyone's probably heard of, and back when you used to see commercials for all this stuff, the little blue pill or the 2 people in the bathtub on a hill overlooking the sunset, you know, those were the Viagra and Cialis commercials back from the day. You haven't seen those commercials in years, right? That's great news. That means it's generic. That means it's cheap. It means no one can afford to pay for the commercials anymore because that's you ultimately paying for those commercials, right? All right, we'll try and keep the politics out of this. So Viagra and Cialis now are less than 50 cents a pill, right? So it's gotten a lot easier to prescribe those medications if your insurance doesn't cover them. Kind of mid to late 90s, if Viagra wasn't covered, it was $40-some a pill, right? So from the beginning, these things were kind of price exclusive if your insurance didn't cover it. And traditionally, Medicare has never been great about covering erectile dysfunction, although interestingly enough, when we get to this surgical treatment, they've always covered that. Until this day, they still cover that. But these medications called PDE5 inhibitors are to enhance or increase the blood flow. So what they do is basically just amplify your signal. So the first thing I have to warn my patients if they're going to try one of these pills, we'll use the generic names called sildenafil, tadalafil. Those are the generic names for those 2 drugs. You have to try to do something sexual. So if a patient says, yeah, I've tried Viagra a few times and nothing happened, I'll say, well, how did you try it? When did you take it? Did you take it on an empty stomach? And what did you try to do afterwards? Because if you just take it and watch sports on television, nothing's going to happen, right? You have to start that process, and it just makes that process better. So I kind of tell patients it's kind of like turning the volume up, right? You got to start this, and we'll turn the volume up. But having a kid who just kind of moved into high school and doing math homework with him, you know, it reminded me that anything times 0 is always 0. So no attempt at anything is still 0. Or unfortunately with prostate surgery, if the nerves are permanently damaged, that signal never reaches the penis. So that is still a signal of 0. So sometimes after prostate surgery, these pills don't work. And if you're not trying to do anything at all, of course they don't work, right? But they enhance that blood flow. So there are medications to enhance the blood flow. Those are those ones we just talked about. But there's also injections. So we talk about this guy with prostate cancer treatment or a prostatectomy where his nerves were damaged. Well, how do we get that blood flow to increase if we can't get that nerve signal there that says, hey, it's time for an erection? Well, actually, we have a shot to do that. Guys get nervous about it because the shot goes where they think it's going to go. It's a little tiny shot into the side of the penis. I try to calm guys down after I tell them that. It's a smaller needle than diabetics use. The actual shot itself is not felt really to a high degree. The side of the penis has no more nerves than any other place on your body. It's the tip of the penis we call the glans that has all those nerve endings for enjoyment, but also potentially for pain. So these medications bypass everything before that, right? So when I'm talking about erections, even with young people, I'll talk to them about the 3 phases or the 3 things that need to be involved. You have to psychologically be prepared. You have to have a partner you're interested in. You have to be sexually excited. If you just got in a fight, if you were at work for 14 hours and you're home and you're tired, like all these things mentally will interfere, right? So we got to make sure that's all in order. But once you're in that mood, you're aroused, you're excited, and things should be happening, that signal has to transmit to your genital area via the nervous system. If those nerves are damaged, whether that be surgery, diabetes, or anything of the like, then that signal might not get there. But if the blood flow is intact, then ultimately, if we can trigger that blood flow, we can get an erection. So that injection bypasses the first two phases. It will give you an erection even if you are watching sports on TV. Once you've done the shot does what the shot does. So it chemically increases the blood flow. And so in patients who the other medications haven't worked, it will work for a lot of those people unless it's a blood flow problem. We can only overcome that blood flow problem to a certain extent. So let's say the arteries are quite narrowed, just like somebody's arteries if they've had a heart attack. I might not be able to pump that blood flow up enough. So guys who aren't successful with the shots, then we know it's because it's a blood flow problem. So what do we do if we fail those other treatments? That's the next section. Yes?
So the gentlemen are giving the shot themselves?
Yes. It's a very quick acting process. Within like 3 to 5 minutes, it usually starts to work. So you don't need 1 to 2 hours of advance notice with the pills. Just kind of have to excuse yourself for a minute. You do the shot, you return, it starts to do its thing. Once we've adjusted the doses with people, it's very predictable and reliable for the most part. When I teach patients how to do it, we do the first session together in the office. You get the medication, you bring it in. I teach you how to do the shot. We do the first shot together. We have you sit there for 45 minutes to an hour, and we judge the response. How strong does it get? How long does it take? The problem with these injections is what we call a prolonged erection or priapism. If you do one of these shots and it's too strong, you get an erection for hours and it won't go down. That becomes its own problem. After 4 to 6 hours, it becomes painful and starts to cause potentially future damage. So these are all safety things we go through. We're not going to get too much into the specifics of that, but if people have questions, we can. But the injection is sometimes an underutilized option in guys, either because they're nervous, they're concerned, it's not offered to them by their physician, or maybe they try it once and have a bad result and don't adjust it properly. So I think it's probably underutilized. Some of these injections are not covered. Medicare specifically doesn't cover these injections, so we're often getting them from compounding pharmacies that make them, that sell them at a much cheaper price, but we're in the less than $10 per injection range usually for those. Okay. Any other questions before we move on to potential surgical options? So myself as a urologist who specializes in sexual dysfunction, I do a lot with like penile prosthesis. There are some other newer things coming out that are more procedural rather than surgical. A lot of them aren't ready quite for prime time, but if you're talking about what might be out there in the next couple of years, well, I really think the next big thing is going to be low intensity shockwave treatment for the penis. What that does is use kind of high frequency sound waves at a low intensity to kind of almost at a microscopic cellular level damage things a little bit. Sounds weird, but like if you're a muscle builder, weightlifter, what they're doing with heavy lifting is breaking down the muscle to rebuild it. Sometimes you got to tear something down to rebuild it. So this low intensity shockwave treatment is not painful, but at the cellular level is causing some micro trauma that stimulates regrowth, right? So there have been studies that show that this low intensity shockwave treatment might generate new blood vessel growth. These machines are actually approved in Europe by their version of the FDA. So it's being done in Europe. There's 7 or 8 years worth of studies there. It's not FDA approved in the US. The machine you would use for it is FDA cleared, but the process of using it on the penis is not FDA approved. No insurance is even enough. I'm trying to get a machine so we can offer it to patients. Right now, if you see it online or you read about it, unfortunately, there's always people who are going to take advantage of things. And so there are people online selling a home version of it, which there's no research to show that it helps. And I've had patients come in and spend $800, $900 on this home device thinking it's the same thing, and it's not. The machine we're trying to get for our office is a $50,000 machine. And there are places, there's 1 or 2 places in Michigan doing it. I had a patient recently go to Chicago and get it done because I don't have the machine yet, and he's been patient, but after a while he was like, hey, you're talking so much about it, I'm just gonna go get it somewhere else till you can get your machine. But right now it's cash-based treatments, and it's anywhere from $3,000 to $5,000 for the 6 to 8 treatments involved because it's not covered by insurance. Right now, even if I get the machine, it's not covered by insurance, it's gonna be cost prohibitive for a lot of people. Other things on the horizon, there's this thing called a P-shot, which is an injection of another kind of regenerative material. Stem cells might be out there someday, but once again, that's going to be a long ways off, and that's going to be a lot of regulation involved in how we do that and what happens there. So I think the next biggest thing is going to be this low intensity shock wave. But currently, one of the treatments we have for people who fail all the other treatments is a penile prosthesis. And so unfortunately, some guys get to this point sooner than others. I would say the average patient is in my practice 3 to 5 years before we do a penile implant, unless they were referred to me by another doctor where the patient's probably been in their practice for 3 to 5 years and they've said, I'm interested in it, then they come see me just to have it, because that's a big area of my subspecialty. But it's a tough decision for some people to reach about whether or not I'm ready for a surgical procedure for this, but especially in people who failed other treatments, a good option. There's a couple different devices out there, Coloplast, AMS, a new one on the market called Rigicon. That's really the only new thing, is that there's kind of a new car manufacturer, so to speak, right? So people ask me, well, which one's better? It's the difference between a Ford, Chevy, Buick, Pontiac, Tesla, whatever it is. They're just different models. They've all got tires and wheels and some kind of engine. They work in the same way. Different ones are right for different people. So there are some things I like more or less about one or the other, and sometimes we'll pick ones for different people based on that. They're long lasting. Most people will get at least 10 years plus out of use of one of these devices if we put one in. What's the recovery? What's the downside? Most of the complications have to do with the recovery from surgery. Try not to mislead my patients about this. It is at least a 2-week recovery process. So it's going to be a little bruised, a little swollen. It's going to be a little uncomfortable. We leave it partially inflated at first. It's like having half an erection. So the first 2 weeks are like an investment in your future. But after about 2 weeks, we can let the pressure off. The bruising and the swelling is gone. The pain is much better. And in 4 to 6 weeks, the device is usually ready to use. We're not talking about months of recovery like an orthopedic surgery that requires a lot of rehabilitation or anything like that. But we are talking about surgery. We're talking about anesthesia. The biggest risk we worry about is implant surgeons, just like orthopedic doctors, would be an infection. An infection after one of these procedures can be a problem. Sometimes you have to go back in and remove the implant device. But in young, healthy, or healthy non-diabetic people, that risk is probably less than 1.5%. In diabetics, it's a little higher, maybe 5 to 7%. So not something that I would usually have talk people out of it, but something we ought to talk about when we're going through the risks. Expectations, I want to manage people's expectations with any treatments we do. Like, what's the best case scenario for me, right? I don't want people to go into surgery for the implant thinking this is going to make them like they're 20-something years old again. I want them to think about the 2 weeks before surgery. How was my sexual activity 2 weeks before surgery? Was I able to penetrate? Was I satisfied? Was my partner satisfied? What was the predictability of how often I could get an erection that I could use to perform? And so we want to kind of look at the before and after there, not what was it long ago, but what was it right now? And if it's better, if it's more predictable, if it's stronger, if you can have the activities you like to enjoy, then we're going to consider that a success. So we want to go into it with those expectations. I put this section in a little bit later about hypogonadism, or what we used to call menopause. There was a Time article once a couple of years ago where it had on the cover of it a guy with his shirt off who was reasonably fit but 60-something years old, and it said menopause on the top. What kind of got us in a lot of trouble with some people, the FDA and things like that, like we were pushing drugs on people, right? So there is something called low testosterone of the aging population, right? It's an inevitability in men. Our testosterone goes down with age. But this is where men and women are different. Menopause, not menopause, right? We're using that wordplay here. Menopause in women happens over a couple of years, more suddenly, faster, more noticeable, right? I think women would tell you, hey, no big deal, this is what happens to us, but it happens more quickly, it's more noticeable, and women are more likely to be talking to each other about it, right? Hot flashes, tiredness, fatigue, changes in the genital area, those kind of things. When men, we lose about 1% of our testosterone per year starting in our 30s. So if you're losing 1% per year, that's not a big drastic change, but between the ages of 30 and 60, 65, you might have a very substantial overall drop in your testosterone. So I more commonly hear, just boy, in the last 5 or 10 years, I'm more tired, I'm more fatigued, I'm having sexual dysfunction, getting mood swings. I'm in the gym 5 days a week and I'm eating healthy and I'm gaining weight and losing muscle, those kind of things, right? So this menopause term was more just a play on words to get education out there, but I think people thought we were kind of pushing testosterone on them. But no, we're also talking lifestyle changes, diet, exercise, weight loss, those kind of things will help you maintain your testosterone, improve your testosterone to a certain degree. But if we have somebody who, let's say, is almost clinically depressed, no sexual drive, 30 pounds overweight, even though they're eating right and exercising, in some of those people, testosterone probably is the right option, right? I do a lot of testosterone work with people, so think I was a little disappointed when urologists got accused of kind of drug pushing for this. But what happened is when the education really got out there, the prescriptions did go up. But I feel it was more an educational thing. More people came in, more people asked about it, more people were treated. I think we were underserving men with hypogonadism for a long time. And that surge in prescriptions in the early 2000s was just doctors and patients being more in tune with what it was, right? It was out there, we just weren't treating it. We weren't all of a sudden giving drugs to people who didn't need it, right? So it's a little easier in the younger population that has that to have that discussion, but if you're 70 years old and your testosterone is low, is that from natural aging? Maybe, but if it's causing symptoms, are we not going to treat it? That's a discussion I'll have with my patients, right? It has to do with how we're going to do it, what are the side effects, what are the safety, right? So we'll talk about testosterone and what are some of the symptoms of low testosterone. So fatigue and low libido, those are probably the first two things I'll hear from patients, right? They'll come in sometimes asking me about their testosterone because they've read it online now because we have a lot more patient education out there, and they'll say, I think my testosterone's low. So my first question is, what makes you say that? I'm tired, I'm fatigued, my libido's not the same as it used to be. Okay, and we'll get into some more details, talk a little bit about irritability, mood changes, muscle loss, difficulty concentrating. Some people just feel like they've lost that mental sharpness. So if it happens to people, especially earlier in their 40s and 50s, and they're like, boy, I just can't concentrate, I can't remember phone numbers like I used to. Somebody 70 years old and that happens, they're just writing it off as aging, right? But maybe it's their low testosterone as well, right? So some of those memory changes can be related to low testosterone. So understanding testosterone replacement and what the side effects and symptoms are, this is kind of like on one side, what if our testosterone's terrific and what if it's low, right? So confusion, sharper mind, happy, depressed, increased risk of Alzheimer's and memory changes, more fat, healthier lean muscle, stronger sexual drive and erections. Low testosterone can cause risk of osteoporosis. So if you're stronger, healthier, more motivated to work out, stronger bone health. So there are some advantages. There was some pushback a few years ago about possible cardiac risks of testosterone replacement. 3 or 4 articles in the early 2000s that said there was an increased risk of heart attack and stroke. Well, there are 4 times as many articles that say maybe there's a decreased risk of heart attack and stroke. So once again, that was a controversy. I've got a 2-hour lecture I've given to primary care doctors about those 4 papers and why I personally think they were poor science. So whether or not it helps or hurts your heart is going to be debatable, but if it's done properly, followed properly, I feel like it's of low risk, okay? But actual low testosterone itself has been shown to be an increased cardiac risk. So having low testosterone for multiple years might put you at a higher risk all by itself of a heart attack or a stroke. So how do we diagnose it? We just talked about signs and symptoms, right? So once again, like I said before, the interaction with the patients and the history is an important part for me. So we'll go through all those questions and symptoms we just talked about. But at the end of the day, if we say, yes, that sounds like it might be low testosterone, we get a blood test. Your testosterone blood test should be done in the morning. You want to get it a few hours after waking up. That'll give you your best estimate of a good testosterone. Peaks in the morning, goes down a little later in the day. So we'll do a testosterone test in the morning. If the first one's low, we'll usually repeat it. So instead of jumping on that first test and giving somebody some kind of testosterone right away, we might repeat it again and just make sure we have 2 morning levels that are low along with your symptoms. To me, that's enough for a diagnosis. So forms of testosterone replacement. Testosterone injections have been out for a long time, but traditionally they were given in a doctor's office. I don't give any testosterone shots in my office anymore. If someone's going to be on testosterone shots, we teach them how to do it at home. Coming to my office once every 2 weeks or once a month for an injection is just not an efficient way for our office to use their time or for you to do a treatment, because that's not the best way it works. These shots last 7 to 10 days. So if you come into my office once a month for a shot, what's happening in your body the rest of the 3 weeks? Testosterone's going back down. So the injections, if they're to be used, have to be used on a shorter interval than that. And coming to your doctor's office once or twice a week is just not a long-term realistic option, right? These medications are cheap, they're effective, they've been around for a long time. If people aren't afraid of needles, we can teach you how to do subcutaneous injections, which is that top one. You can do them in the skin or the fat of the thigh, around the midsection, behind the arms, the buttocks. That's a subcutaneous injection. Or intramuscular is how it used to be given traditionally only, kind of in the upper outer hip or in the thigh. So intramuscular or subcutaneous injections. There is now available, if your insurance covers it, an auto injector where it's already preloaded and you just take the cap off like all these other medications. pinch a little bit of area on your side and give yourself a little shot right there once a week. Very convenient, unless people are just that afraid of even the word needle, because that one you don't even have to see it, right? You just hear a little snap when it happens. You almost don't feel it. So injection's a good option. We'll talk a little bit more about some other forms of testosterone therapy too. What are some possible side effects, especially of the injections? So any testosterone replacement can cause acne or oilier skin. So I'll usually talk to guys about watch for things that used to happen to you during puberty: irritability, acne, weight changes. So if your skin's breaking out, if you get breast or chest changes, if you get mood swings, if you have sleep disturbances, those are all things you can notice. You might notice the same small change in the size of the testicles. And if people are young, we talk about fertility, because if you start giving testosterone to somebody in their 20s or 30s who isn't finished with their family-bearing years, you can drop their sperm counts dramatically. So I'll see some guys come in to see me that have been on testosterone and they're 30 years old, don't have any children. They've been trying for a few years, and we figure out, well, it's because they've been on testosterone already for a while, and nobody mentioned to them that it's almost like birth control in some people. So we have to be careful in younger people about testosterone there. Diet, exercise, weight loss, that will all enhance your testosterone to a certain percentage. So if somebody's borderline, they're not too low, but they're just feeling some of those symptoms. Major weight loss, now we're talking 30 to 50 pounds, can make a major difference in your mood, your energy, your testosterone. So exercise, appropriate sleep habits, all those things are going to be important. Quitting smoking, making sure your diabetes is controlled, all those things. If someone's on testosterone, follow-up is very important, right? So increases in your red blood cell count, monitoring your PSA test for your prostate. Testosterone doesn't cause prostate cancer, but if you've got prostate cancer when you're on testosterone, it can move faster. So we monitor the PSA maybe even more closely in guys on testosterone. And then once a year, cholesterol panels, liver panels, that kind of stuff. So if someone is on testosterone, it ends up being a long process, right? If we're giving you testosterone, you feel better. We stop giving it to you, you'll go back to how you were. So when people ask me, am I going to be on this the rest of my life? Maybe, if it makes you feel better. But that's signing up for that monitoring. So this is up here just, old-fashioned calendar. Everyone uses their phone now, but you're going to have doctor's visits and follow-ups involved in testosterone should you choose to be on it. I guess my slide on other testosterone therapies wasn't in there. We have the first testosterone oral therapy in many years. There was 30 years ago, a testosterone pill got pulled off the market because of liver damage. They've now re-engineered it in a safe way where there's a testosterone pill available. There's a nasal gel, there's a topical gel. There used to be a topical patch, but that's off the market, at least for now. There's a once every 10-week shot you can get in your doctor's office. If you're just not able to do the other treatments and can't do your own shots at home. So there's an every 10-week shot you can do in your doctor's office, like a long-acting one. There's a little tablet you can put under your lip. We call it a buccal mucosal tab. There's testosterone pellet implants that you can do kind of in the upper outer thigh, and you can do that every couple of months. But with some of the other treatments being easier, I do fewer of those treatments now. So we got a lot of different options for testosterone replacement. Before we move into this last quick section, which will be short, any questions on that? Yes.
Sorry, it's not really applicable to us, but it's important, I think. Why would a man in his 20s or 30s be on testosterone? Just curious, is it for treating depression or wanting to be a bodybuilder?
So you'll see people come in that used to do it because they were semi-pro athletes or got it from the gym. And then later they can have long-term problems, like they try to get off of it, but they're doing 10 times or more the doses we're giving. The people who are doing it at the gym are using much, much higher doses than we're using medically. That's important to know there. But then if they do it for years and then they stop, they may have lost their own ability to produce it. Well, now they've created a real medical problem. So let's say you're 37 and for 10 years you've been on steroids at the gym and you want to get off and be healthy. Well, now your testosterone might be really low. And then now you're tired and fatigued and depressed. You can't keep any muscle when you're used to being a big person. You're getting mood swings. Then we're going to probably put that person on a medical version of testosterone, not what they used to take, but to level those symptoms. But there's multiple other reasons people get low testosterone earlier other than the aging part. Testicular cancer, you get one testicle removed. Some people for unexplained reasons, pituitary problems in the brain. Other medications can sometimes interfere with it. Probably 30% of my testosterone population is under the age of 50. And so I'll get guys a lot of times in their 40s. What changed in the last 3 years? I don't feel like the same person. Fighting with my partner more, the erections aren't nearly the same. I still feel like my partner's attractive, but I'm okay if we have sex once a month. We used to do it 2 or 3 times a week, you know. We start talking about those symptoms, we check their testosterone, it's low, and we might not find out exactly why. Or some people just start at a lower level, right? You talk about statistics, there's this bell-shaped curve. So some people, when they're in their 20s, their testosterone's 800, 900. They drop 400 points, they're still 400, they might feel okay. You started at 400 in your 20s, and you drop to 250, well, that's a bigger difference sometimes. So we don't check testosterone on 20 years old and we're healthy. So we don't know what your testosterone was when you felt vibrant, right? Maybe we will someday, just so we know in the future what we're trying to get back to. So that's why I'm just more focused on the symptoms, and if we get a test and it's low, we'll talk about treatment. Okay. So the last question, just kind of general recommendations. We talked about this already. Balanced diets, weight loss, cholesterol watching, watching your hypertension, treating your diabetes, regular physical exercise, right? So physical exercise has been shown to increase your sleep, improve your erections, increase muscle and metabolic activity, change your insulin sensitivities for diabetes. So really, you can't overstress the place we're in here, the MAC, providing those facilities for people to exercise, especially while it's raining outside or we have a foot of snow like we do here in Michigan. So maybe if you're in a place where it's always sunshine and beaches, then it's easier to get outside and exercise. But here it's nice we've got a facility like this. So diet, exercise, always going to be stressed by your urologist as far as sexual health, functional health, testosterone, and even urologic health, like 30, 40, 50-pound weight losses in people who are heavy can help their urination as well. Regular checkups. So we talked about PSA screening. We talked about digital rectal exams. Not everybody has to see a urologist every year, but if you have any of this stuff we talked about today, maybe you should be seeing a urologist every year. Or if you feel like your primary care doctor isn't listening to some of the concerns you have, then that would be a reason to see a urologist. But I see more and more primary care doctors who are in tune with these things, and they're offering the medications, and they're starting people on Viagra, Cialis, maybe even testosterone, even though if sometimes they're not comfortable with that, they'll refer them to me and say, I think this patient might need it, but I'm going to refer them to urologist. So I get a lot of those referrals from primary care doctors who recognize the problem, but maybe aren't as in tune with some of the treatments or the therapies or want the specialist to take over. So getting a yearly checkup in men is sometimes not as easy as it sounds, right? I think the younger generations coming through seem to be a little more in tune with it, but people, my generation, your generation and up, kind of a lot of guys were like, I feel healthy. I don't need to go to the doctor until something goes wrong. Sometimes that first thing going wrong is sexual problems or urinary problems. So I have a lot of patients who I'm their primary physician. I see them more than any other doctor. That's sometimes how it starts. I diagnose several people a year with diabetes. They come in to see me, they're having sexual problems. We do a urine screen, it's got glucose on it. I ask them questions about their diabetes and they're like, what diabetes? Well, you probably have diabetes, you didn't know it, you haven't seen another doctor in 8 years. Let's get you in with an internist and figure out what's going on, right? So I think that yearly checkup and that health maintenance, right? Don't wait for something to go wrong with you. Keep up on your maintenance, right? You don't want to end up with a flat tire on the side of the road. You want to prevent the maintenance, right? So that's kind of my analogy with patients. Let's keep things healthy. Let's keep them working, okay? So in the interest of time, we'll stop there, okay? But we've got a few more minutes for questions. Yes?
Dr. Bennett, thank you for your time. 2 questions for you. You talked about erectile dysfunction and the treatments, whether it's pills, gels, or shots. Regarding mostly senior citizens and what insurance doesn't and does not cover, out of the treatments, the pills, shots, or the gels, what can you tell us about what the insurance likely does and does not cover? And then secondly, you talked about erectile dysfunction and fatigue, etc. That speaks mainly to the male side of the picture, but can you picture what that is?
So the first part, if you're talking specifically about testosterone, it gets really complicated with all the different insurance variations now, right? So in general, usually with Medicare, I can get one of a couple things approved for people, but it depends sometimes on your Advantage program, right? The testosterone gels are covered in most Medicare age people. The shots are almost always covered on any insurance because they're the cheapest. The things I have the hardest time getting approved are the new oral testosterone pills because anything new on the market takes a few years. So it's kind of 50-50 on whether I can get those approved for patients. So usually in Medicare aged patients, I'm starting with either the gel or a generic shot. because we know we've got our best chance of getting those covered and having them work. If we're talking about the female side of sexual dysfunction, we'll see my partner, Dr. Bartley, later this year. We'll get more into it with that. In the female sexual dysfunction side, there's kind of two subgroups there, right? What we call dyspareunia, pain with sexual activity, right? So a big barrier for women is pain with sexual activity, especially after menopause. Estrogen levels change. That changes the genital environment in the vaginal area, thins the lining, decreases the lubricants, and just makes sex. If your partner's having any issues, then people just kind of drift away over time, right? And they stop trying and they stop trying to get improvements. So I send a lot of my patients back to their partners to talk to them about what kind of things are we involved in. And especially if someone's coming to see me for an implant surgery without their partner with them, I ask them if they discuss this with their partner. What's their partner's level of interest? Does their partner feel like they'll be able to participate if we do this surgery? So before we go do this surgery, let's make sure everyone's on the same page. And sometimes we're sending those partners back to their OBGYNs. So I feel like a lot more OBGYNs deal with this than maybe urologists. There's fewer urologists than OBGYNs. Women see their OBGYN on a more regular basis than they see a urologist. So there's topical vaginal hormones they can use to help change the environments back closer to what they were, to help with the dyspareunia part of it. There are also medications now approved for female sexual dysfunction. Boy, I wish I was more interested in sex than I'm not. There are actually a couple medications for women to potentially try there to help them feel more interested, in addition to the barriers physically like pain. I didn't get too much into it, but I'm usually asking my male patients about their female partners and whether they've discussed this with them, and often saying, well, if your partner is interested, maybe have them also discuss it with their OBGYN. Yes, in the back.
Are you seeing a correlation between Menards and either the BPH or the erectile dysfunction? Both circulation.
So Raynaud's, you like where your fingers get. So that's kind of on that microvascular level, like temperature changes really affect the blood flow in some people. Not the BPH so much, like the prostate growth, right? That would be pretty consistent. I don't think that would be involved. I haven't seen many studies though on Raynaud's and erectile dysfunction. Different blood vessels, like different blood vessel sizes, right? Like Raynaud's people don't go outside in the cold and have chest pain like they're having a heart attack. So it'd be, I'm curious to know in a really good, theoretically, change in that pain, right? That I've never heard. Like Raynaud's patients don't get the same response in the penis like they do in their fingers and their toes. And so I don't think it's a consistent problem with those patients. If somebody has Raynaud's and erectile dysfunction, it's more likely all the other things we talked about that can happen to any guy. And the treatments would still be the same. Promote the blood. Anyone else? I know we ran a little long. Thank you for your time. I'll hang out for a couple minutes if there's other questions. Thank you.